Convening today's meeting, and I'm going to start with a roll call. So I do want to recognize our Vice Chair, Dawn Montner. She will not be here until 10. So I will start with Greg. Greg, I see you here. Thank you. Chicky, I believe I saw you on the list as being here. Chicky? Yes, hello, good morning. All right, Andy, I see you. And Kimberly, I see you on screen as well. Good morning. Now, Emily, I saw Emily hop on. Emily, are you here with us? Give Emily a moment. Yeah. Great. Good morning, Emily. All right, so we do have a quorum. I do want to recognize that. Good morning. I want to recognize we have lots of people with internet issues today. We'll see how it goes with the presentations. Hopefully all of our presenters are able to be online. I'm going to start to see if anyone wants to make a motion to approve the minutes. And just so you all know, I asked for one typo to be corrected so that it's clear that our plans do not cover doula services. So that'll get reflected. There was a small typo that rather than say they do not cover, there was a slight typo there. So we just want to be clear, our current plans don't cover the doula services. So do I have a motion for the minutes from our December meeting?
I can make a motion.
Great, thanks, Greg. Do I have a second?
I'll second. It's Andy.
Thanks, Andy. All right, Chicky, how do you vote on the minutes?
I vote to approve.
Thank you. Kimberly, how do you vote?
Approve.
Thank you. And Emily, how do you vote?
Approve.
All right, thank you. So our December minutes are approved. All right, so we are going to be moving to a risk-based capital report. This is about our stabilization fund, and Emery should be leading for us from Mercer today. So Emery, are you on?
Yes, I am.
Yes, there you are. Great. I'll hand it over to you.
Thank you, Chair. So this is the first of two presentations I'm going to be providing. This first one, they kind of take a look at the performance and future performance of the plans. They kind of look at it differently. So the Risk Stabilization Fund does provide an update on the most recent claims, but it also looks forward over the next few years. And this is kind of important in terms of the renewal process, where we take a look at the projected costs over the next couple of years compared to the funding that's coming in for PEBB, which is essentially the 3.4%. So any delta, any difference between the costs and the funding essentially would hopefully be, made up by lower trends, but sometimes it might not. So you might have to take a look at potentially, finding ways to save money to meet that 3.4% in the future. So that's essentially the purpose of this report, as well as taking a look at the amount of funds, stabilization funds that might be needed to cover any potential fluctuations in claims, especially, I guess, in, higher utilization or increased trends that are unexpected. So that's essentially the point of this report. We do take a look at, do some Monte Carlo modeling to take a look at fluctuations, but we, hopefully as we take a look at this report, costs aren't increasing too much, and that, there's enough funding there, and so that the PEBB is in a good place over the next few years. We do use the NAIC. Let's move to the next slide, please. We do use, next slide, please. Thank you. We do use the NAIC risk-based capital, or RBC, to determine the amount of amount of stabilization funds that's needed to cover the expected fluctuations in claims and potential underwriting risks. Underwriting risk is basically where we take the claims and we project that forward, but depending on certain situations, like the base claims might not quite accurately match, or there's risk in terms of higher costs, and in terms of the hospitals and contracting, there's more concern about providers asking and requiring more higher rates, and that does impact PEB. And so that sort of uncertainty, that sort of risk is what we're trying to cover for by having this RBC stabilization fund and enough budget essentially to cover those costs. Next slide, please. Yeah, so just kind of to talk again about the fluctuation in claims, you have to base your claims, you do the underwriting, which is essentially applying trend, any changes in the program costs, and in some cases, legislation, with the short legislative session coming up, that will impact the cost to PEB. And currently, as those are not currently funded and are not part of that 3.4 limitation, it does impact PEB. And so some of that RBC target is used to help cover some of that legislation, some additional costs there. And also in any other changes in the Oregon landscape in terms of the members or the hospitals, or large claims fluctuation, that's essentially uncertainty that we're trying to cover for in the projected costs. And that's what this report's trying to show. Next slide. Thanks. So, high-level results. So the good news is that the claims, when we compared to the last time we took a look at this, which was about 6 months ago, the claims are basically the same. It is slightly higher, like we're just talking a couple $1 few $1 million higher. But overall, having a 6-month time period and just seeing the claims projected costs change by a few $1 million, basically means that your costs are pretty stable. That's good news. However, the trend rates that we've been using for now are a bit higher than we have been in the past. So that does mean that while your claims are pretty stable, costs are kind of increasing higher than it has been historically for PEB by like 1%, couple percent. So that does impact projections going forward. Right now, we're saying there's going to be a surplus of 41 million, which is about $4 million decrease overall on the $1 billion budget, $1 billion plus budget. That's very minimal in this case. 2024 remains in the surplus position, although it's a small surplus of about $9 million. When we take a look to the future years, there is a $90 million transfer that's coming out of the fund in 2025. That was part of the legislation. And then in I think 2023, and then in 26, there is going to be a penalty we estimate at about $9 million as a result of that transfer. Essentially, the funds that are being transferred out, some of it was general funds that were for express purpose for federal, based on federal funding coming in. So basically, because the money is being moved to a place being used not for benefits, there is going to be a penalty of $9 million. Looking into the future, the stabilization fund, it's going to be fine until 2026. It's going to be a little bit below the target, $32 million in 2026. The target is about $280 million. So it's not hugely below, but it is going to be below if costs are cut to keep at that 3.4% funding coming in. But I guess the fifth point in terms of higher trend, just showing if we do have higher trend than expected, in this case 2%, the fund will drop below the target 25. So there will potentially need to be bigger cuts made to reach that 3.4% in 25. But overall, compared to where we were 6 months ago, the story is basically the same. So nothing much has changed Nothing much has changed for PEB. Overall costs are pretty steady, and it's looking in the okay position, at least in the short term, as long as trends don't increase too much. Before I move on, just any quick questions, comments, thoughts? No? Okay.
So,
yeah, go
Emery,
ahead.
I mean, I know that the adding the GLP-1 drugs is the big question mark out there. So that's
Yes.
not factored into this discussion, right?
That is not factored in.
Okay,
It's
thank
basically it's based on all of the renewal decisions that have been made to this point, and GLP-1s is still on hold. So GLP-1s, if it is, let's just say $10 million per year. So that would essentially take out the surplus. If it was implemented now, that would take out the surplus for 24, and then it would put 25 in the position where you would have to essentially, I guess, we can move on. We can talk about in some of the next slides, but it might put you in the position where, at least for the year, you might have to offset it to meet the 3.4%. But it does have a long-term cost every single year moving forward.
Okay, thanks.
Next slide, please. So this takes a look at the fund balance from 23 to 26. So we restate 23. We do use the updated enrollment as of December and updated claims in this case. Oh, yeah, that's real. Yeah, it's December, it's not June. So claims as of November. So we do project out, we do take a look at the latest claims and enrollment, and we project out the costs. So basically, based on that, the funding balance for 23 still is in a good position compared to the target. So we're about $392 million compared to $233 million, $234 million target. In 24, you did meet the 3.4% target. And so the fund balance does grow slightly compared to the target. And then moving on to 2025, right now, that big drop mostly is due to the $90 million amount that's being taken out. But even with the $90 million transfer out of the stabilization fund, you are above the target. And then, but that's assuming that you don't make changes to keep to the 3.4%. In 26, just basically letting costs flow through and funding at 3.4%. That does take you below the reserve target in this case, although it's not significant. Yes, you can see it's just kind of like with just below the bottom end of the reserve target, but it's still in a relatively healthy position. But this essentially means that you're not making changes to meet the 3.4% requirement, and then you're basically deficit spending to cover costs and claims at the current plan level, essentially. Next slide. So on a year-by-year basis, you can take a look at the costs versus funding. So the funding is in green, and that's after all of the enrollment changes and plan changes, and then the costs are there in blue. So overall, for 22 and 23 and even 24, the funding is actually higher than the cost. So you're adding to the surplus. And for 25, the costs and the funding right now are pretty close. So it doesn't look like for this year, assuming this upcoming renewal cycle, there's not going to be significant plan changes are going to be needed to be made to meet that 3.4% increase or budget limitation. Some of that's due to the funding assessment that was applied in 24. Basically, you're coming in below the 3.4%, but you applied the funding assessment to essentially create a buffer in terms of the funding. And so that helps with some of it. And the other portion of it is, the costs are pretty close to, the trend rates. And so overall, doesn't look like you're going to have to make big changes for 25. However, if you do add GLP-1 drugs, that's an additional cost on the blue, which does take you above the funding by that much more. So, as mentioned before, I mean, if you were going to add GLP-1s without no offsetting adjustments, it is going to basically require potential deficit spending or adjustments to meet that 3.4% limitation. And then for 26, because funding is projected to increase at 3.4 based on limitation, but the trends are higher, that the costs do come in higher than the funding. And so there's a bigger delta, a bigger deficit in 26. So overall, at least for 25, you're in a pretty good, decent position. There might be a little bit of plan changes or some adjustment savings that might be needed to meet that 3.4% limitation. But 26, the costs start to, assuming that trend grows and costs grow at the same rate as they currently are, there is going to be more changes or more adjustment that might be needed to meet that 3.4% limitation. Next slide, please. So just a longer term look at the historical cost increases. And we have a slide in the renewal primer that kind of shows how well, PEB has been keeping to that limitation. And this is the overall cost increases from year to year. And PEB has been below 3.4% since 2018. Um, in 2018, the costs were a bit higher, but then 2019 met to 3.4%. 2020, as we all know, COVID did just kind of changed healthcare quite a bit. There were savings or lower costs, and then rebounded services in 21. And then since that, 22 and 23, overall costs haven't increased that much, pretty close to 3.4% if you take a look at on average. But you're still kind of having that surplus from 2020 that's carrying forward. 2024, the costs are a bit higher. The increased projected cost is 7.9%, but that still keeps you below that 3.4% limitation if we take a look at it on the uh, long-term frame. Next slide, please. So this slide kind of shows the impacts if you keep at the 3.4%. So making some adjustments for small adjustments for 25 and then 26, some bigger adjustments. It does keep you above the reserve target, even with the $90 million transfer out and the penalty. But as mentioned before in some of the other slides, that does require some belt tightening in this case, just making sure that the costs are closer. For 25, not significant changes, but 26 bigger changes in order to keep at that 20 at the above the surplus or the 3.4% limitation. And we, it it's there are some changes that will hopefully, well, not change, there are things hopefully that can be done to keep costs down, and we have been meeting that per year, but right now, it is costs are projected to increase higher than the funding. And so there are going to potentially have to be, long-term planning in order to meet that 3.4% limitation in 26 in this case. Next slide, please. So taking a look at the different scenarios. So the 3.4% limitations in purple, that scenario that we just showed. So you can see at the top, this ending fund balance above the target still remains pretty solid. The green line is if no changes were made or deficit spending happens. You do stay above the target in 25, but then 26, you drop about $32 million below. And then the blue line is kind of like the worst case, where you don't make changes and trend increases by 2%. So overall, while 24 is still fine, with 25, with the $90 million transfer out, and a higher trend with no adjustments, you do drop below the target. And then in 26, again, worst case scenario, no changes in deficit spending, you do drop below the target by quite a bit as costs grow much quicker than the funding that's coming into PEP.
Hey, Emery, what is the
Yes.
current market trend? You say
So the current
2%, but what is it? Yeah.
Yeah, so the current market trend is we're saying it's about 6.5% for medical and 10 for pharmacy. So overall, for the blended medical plan, it is about 7.5%. And that's before any plan changes. We do have in the renewal primer, we kind of show where people are coming in, where the other employers are coming in, and they're coming in about 5%, but that's after plan design changes. So about 7% is what we've been seeing over the last couple of years. Um, we'll get the renewal results from initial renewals from Kaiser, Moda, and Providence, and we'll also see what the trend rates that Moda, Providence, and Kaiser are using. Last year, I think Moda and Providence were about that ballpark. Kaiser was a little bit higher, so we'll see what exactly they come up with in the latest renewal. But what Mercer's been seeing has been about that 7.5% for medical, and it has been an increase of couple percent over essentially the last couple of years in this case.
Appreciate that. Thanks. And can you remind the board when we'll get the first numbers in from the carriers?
I want to say it's very soon, like this upcoming week.
Thanks.
Mhm. Next slide, please. So this just kind of go through and just provide some of the highlights here in terms of, I think a lot of this we've talked about before. So Siobhan, to your point, the market trend rates in the teal, it says um, the second section, medical 6.5, pharmacies 10, but that's before rebates. So rebates are taken out from there, and it's 7.2 weighted average. And dental and vision 3.5 and 3 respectively, and those are about percent higher than what we've used historically. Dental costs actually have been a little bit higher than we've seen recently. So we'll revisit that 3.5% for the renewal, but vision has been still trending pretty good comparatively. And then the payments out of the fund, as well as some surcharges, are there in the third. As mentioned earlier, there's the $90 million transfer that's coming out in 25. And then the projections, the scenarios that we have there on the right. Next slide. So these next few slides, thank you. So slide 13 kind of shows the numbers, and then the numbers that are highlighted are the key ones that we talked about in terms of the surplus deficit for the year compared to the endings, and then the other shade down below is the ending stabilization fund compared. And then the line below that's the reserve target. So in this one, you can see that 26 again in or for 26 with the market trends, you do end up $32 million below the target, which is, relatively close, 11% to the target, but it is below. And that's based on essentially not funding or making deficit spending or not making plan changes to adjust the costs coming for PEB. And then next slide, please. And then this one's the 3.4% cost growth, where the stabilization fund remains above the target. In this case, in 26, that kind of keeps you at the 27% surplus, which is actually, overall for PEB, it's actually pretty close what you've been doing in terms of the fund. The costs have been increased, keeping to that 3.4% limitation. So you've been keeping a stabilization fund above the reserve target, which unfortunately, has been there's been transfers out from time to time, but you have been keeping above that reserve target. Next slide, please. And then so the next two just kind of shows how we calculate what the target is for each plan, just additional numbers that you can take a look at your leisure. And that's this RBC presentation. Before move on to the utilization report, I wondered if there's any questions, comments. Okay. All right. So we can move on to the utilization report.
Thanks, Emery. And just since we have this natural pause, I just want to note Representative Nose did join us, and we're expecting Dawn anytime. So I'll let you continue on with the next report.
Okay, thank you, Chair. So the utilization report, again, we take a look at this essentially every 6 months. We take data from the database that PEB uses. And so what we do is we take a look at the claims and different utilization, really kind of dive a little bit more into the actual data, a little bit harder look, and to see what's happening in terms of the PEB costs. So moving on to the next slide. Thank you. So time periods, we do look at it on incurred time period. So essentially when the claim was essentially the service was done. So with that, our time periods that we look at are a little bit delayed. So we do look at, for this report on a fiscal year basis. So the current time period's July 22 to June 23, and then 1 year prior to the year before, and then 2 years, July 20th to June 21. So it is a little bit delayed, although the most updated information based on the RBC, claims are kind of trending at what we're saying is a trend. So we're not seeing huge changes, at least in, there's not a big spike in costs compared to what we're showing here on this utilization report. The self-insured plans are shown there, and the fully insured, the Kaiser plans. Down at the bottom, there's Kaiser utilization in the claims. They don't include what they call integrated care management fees. They do report those as claims in the data and in the experience report data. But they aren't part of essentially the claims feeds. They're kind of like care management services fees, costs that are added on for all services that are performed for PEB members. And so that's about $26 million for the most current time period, and about $25 million for the year prior. So just kind of keep that in mind. And some of the reports we do include it, but other reports they aren't included, and I can just kind of remind you where they, or tell you where they are and aren't reported. But those are additional costs that aren't part of the claims base. Moving on to the next slide. Thank you. Taking a look at the self-insured plans. So these are the claims from the database, incurred claims from database, including rebates. So any medical or pharmacy rebates are taken out of the cost here. Admin fees are not included. This is just purely claims. So as we take a look, the current time periods on the right, and then the 2 years prior are the ones on the left. So the change from the current over the prior is on the far right. In this case, the medical costs in total have increased 2.2%, which is a lot lower than the increase the 1 year prior, that 10.4%. That 10.4%, if you remember from the utilization report, from the RBC report, the COVID time period kind of starts to flow into or impact the 2 year prior costs. You were starting to have the services were still very low in the 2 years prior. So that 1 year prior does include returns of services for medical services. So that 10.4% is really kind of artificially high in this case. The pharmacy increase for the current time period of 11.4% in total. Unfortunately, that is what we're seeing for prescription drugs. Costs are increasing even after rebates. And so on a per employee per year basis, the costs are increasing 8.8%. Medical costs are actually kind of basically it's a very tiny decrease. But that prescription drugs are increasing by quite a bit, and they are above the limitation, the 3.4% limitation. Overall, though, blended, at least on the self-insured cost, it's 1.2%. So it's not increasing that much. And as you know, as we showed before, the overall cost increases, at least for 23, it's in that 3-4% ballpark, for PEB in total. So you are kind of coming in below the limitation, at least for the self-insured cost claims. Next slide, please. On the fully insured, it's a kind of a similar story, although the mix between medical and prescription drug isn't is a little bit different. So on the far right, in total, the medical costs are increasing 4.4%, and if you look at the section below, after and per employee per year, it's actually 2.5%. The prescription drug costs are not increasing nearly as much under Kaiser as they are for the fully insured or self-insured plans. So in total, it's increasing 2.9%, but on a per employee per year basis, it's 1%. So overall, the blended increase is about 2.3% for PEB. And that does include the integrated care management fees, but overall Kaiser costs, at least through June of 23, have been coming in below the 3.4% limitation. Next slide. And when we take a look at it for PEB in total, the cost in that middle on the right-hand side, the per employee per year costs are coming in about 1.4%, which is again below the 3.4, but the prescription drug costs are increasing by about 7.5% on a per employee per month basis. Medical costs haven't been increasing as much. Okay, next slide, please. So taking a look at the trend components, what we do is we kind of take a look at the overall increase, which is at the very top, and then we try to break out the various components of the trend. So overall, the increase is the current year is in blue. The prior year for comparison point is in that kind of red. So you can see the prior year did increase, the total cost did increase by about 11%. But when we take a look at the current year, it's actually about 3.6%. And this is on the per member per month basis. So how is that 3.6% increase? Where is it coming from? It's the biggest increase is really unit cost. So when we take a look at the unit cost, they are increasing about 2.6%. So the majority of that 3.6% is unit cost. The other big portion of the cost increase is member health risk. So basically, this takes a look at the claims, the diagnosis that the members have, and essentially assigns a score to each member. And so the higher the score, the less healthy, more risk there is. And that's tied to, it's supposed to be a proxy for the cost increase per member. Some of that's due to just age, general aging. As you get older, you're going to generally be more expensive. But also certain things like, the types of diagnosis, types of conditions that you have does impact that. So overall, the members, PEB members, are slightly higher risk from prior year to current year, about 1%. 1% is about the typical increase from year to year in terms of the member risk. So that is something that needs to be accounted for. Trying to keep that down as much as possible is some of the things, that we're trying to do with long-term planning to, reduce that risk, with the care management and the chronic care management and stuff like that to bring down that portion of the cost, but it is increasing by about 1%. Utilization has not changed much, at least in the most recent time period. It's a slight decrease. And then cost shared leveraging, this is basically the impact of how much PEB picks up versus how the member picks up. And that's about, basically flat in this case. The prior year, there was a 1.1% increase. The change here is partially due to COVID services. COVID was being picked up in full by PEB, and as fewer lab tests, fewer visits are being done for COVID, members, that cost-free services are not being, there's not as many services like that anymore, and so members are picking up a little bit or not. It's like it does have an impact on cost sharing. So members will have to pay cost sharing for just typical services, but not for COVID. And so that reduction does reduce the overall cost share leveraging impact here. Next slide, please. Taking another look at those different components of trend, we looked at the types of services and where the cost increases are. And if your eyes kind of probably went to the RX slide section of the slide, where the cost increase is 12.7%, and that is a big number. And a lot of it, as you can see there, 10.6% is due to unit cost. So, it's the cost of drugs keep going up, and we'll kind of talk about it. I think we talked about it, over the last few board meetings. We'll show some numbers here, but costs keep increasing. The cost of drugs keep increasing, and it's a big portion of the cost for PEP in this case. And a lot of it does have to do with specialty drugs in this case. The other areas where costs have increased are outpatient facility. So that second column, and then physician services are increasing about 4%, a little bit higher. Unit cost is again big driver of both of those. Outpatient facility does have a little bit more utilization increases. So those are essentially the three drivers of cost here. Inpatient, as you can see there, actually a small decrease or a decrease of 3.4%. And then all others includes lab and radiology. So that big drop there is due to COVID services, lab services not being performed. So some savings there for now, but as we kind of reach, I guess, endemics status for COVID and a certain level of testing and other things happening for COVID, we will be increasing from that point. So unfortunately, we're not going to have kind of like those decreases going on in the future. So the impact of pharmacy and some of the other cost increases will be more impactful as we move on. So COVID's basically kind of, again, having a little bit of impact, reducing the overall cost, but unfortunately, it's not going to last forever. Next slide, please. Taking a look at it by plan, we wanted to see what was really driving the cost changes for each of those plans. So it's like the biggest cost drivers, both positive and negative. Unfortunately, for positive, the first three for self-insured plans, it is specialty drugs, prescription specialty drugs. And you can see those big increases, $11 per member per month from year over year. And so that's really driving the self-insured plans, as mentioned before. There are some inpatient medical cost savings. It's not as many or not as high cost. It's pretty much flat for the inpatient, but especially drugs are really driving the cost increases, at least for this self-insured plans. For Kaiser, again, specialty drugs are the biggest driver for the Kaiser HMO. For Kaiser deductible, mental health outpatient services have been increasing quite a bit and had been increasing, continues to increase, and is the biggest driver there. Professional specialty drugs actually had a drop there, but outpatient surgery is increasing for Kaiser deductible in this case. The types of drugs, I think, it's just we've talked about this in the past in prior meetings. Rheumatoid arthritis drugs are really kind of just driving the biggest cost increases here. For Kaiser, it's immune system deficiencies and chemotherapy, so it's a little bit different. Kaiser's pharmacy costs are a bit different and have been increasing lower, but for the self-insured plans, the rheumatoid arthritis drugs are just really driving the cost increases.
It looks like Representative Nose has a question. Go ahead.
Yes, go ahead.
You're on mute. Yeah, thanks.
Okay, there, found it. Jeez.
Yeah.
I think I know the answer to this, but I can't resist asking. We don't really have much ability as a plan to limit our exposure on some of these drugs. Like just say, we're not going to cover these or utilize these. I realize we try to steer people toward generics and other things that have been on the market that have been affected, but for some of these, this is the only thing that's out there. And we would just come off very, I'm going to use a colorful adjective, mean, if we said, no, we're not going to let, because like this is like otherwise, based on the last report, our plan is fine.
Yeah, your plan's running pretty well, pretty close to market. Unfortunately, the market is that specialty drugs are increasing quite a bit, and that's impacting. Yeah, I don't know if I would use the term mean, because
I used it. You don't have to, okay, but you could say
yes.
yeah.
There are definitely ways that you can try to manage this. I mean, there's different contracting. Kaiser manages their drugs in a different way. Their formulary is much tighter.
Yeah.
And their costs are increasing less. But yeah, I mean, I guess if that does take away, makes a member have to choose or utilize a different drug than what they've been using, it might come across as mean to them. But
I just think, I mean, I want a plan that covers a lot of things. I want innovation to be allowed to come into our plan, okay, but maybe not right away. So that we can say, hey, we can because I feel like it's a value for most of us, which is to have a plan that covers a lot of things, to have good benefit coverage, and to not have it cost us out of pocket very much. And I mean, there's a little bit of me that wants to say, like, look, if you want to have the latest and greatest, newest thing, you're going to have to pay for it out of pocket a little bit until it becomes the standard of care and that cost comes down.
So you're correct that there are a number of very expensive drugs that don't have good clinical options. right? So,
Also, yeah,
yeah, and I think that to your point, that's very true. I think in relationship to, I just saw something called a high performance formulary. There are a number of things you can do to maximize how you're using your pharmacy dollar when there are options. And then I think we've had the big discussion on GLP-1s about the issue that as people might start this very expensive category of
Yeah.
drug, giving them additional support for everything around it to make sure that as money is spent on them, the value accrues to the individual and the population. Those are other kinds of things that can sink in value, if you will. But for most of these drugs, when the pharma discusses pricing, they are saying, well, look at the health value and the long-term impact on cost. But the problem is your cost accrues from day one on the pharmacy side, and the value of a better health status accrues in the 3 to 5 or more year time frame. So those don't track in your annual budget cycle. But I mean, obviously, there are things you can do to maximize the management of these things, but that in itself is a lot of work, as I'm sure you imagine. And some people will be unhappy for, as Emery said, I've been doing this drug for a long time. It works for me. Why are you making me change kind of thing? That's
yeah,
a
I
tough
suspect drugs
conversation to
that
have.
they've been doing for a long time, that those aren't the ones that are driving our cost generally.
It's
It's
you
all-
have to be
it's all-
ready for the new ones.
Yeah.
Yeah.
Ollie, did
Okay.
you want to weigh in here? Go ahead.
Oh, yeah, just thanks, Siobhan. And I just wanted to add that we do depend on the plans to manage the formularies. We don't get a lot of complaints for formulary changes. Obviously, the board has the ability to manage the cost sharing the plans, but yeah, we do depend on the plans to manage their formularies.
Thanks, Holly.
And Emery, I just wanted to
Yes.
double check. So when we're looking at the 1153, the 1034, is that the percent change is what's reflected, or is that the overall?
Yeah, so that 19.6% under the 1153. So the increase, so $11.53 increase represents basically $20% increase in
Right.
prescription specialty drugs for Providence. So it's like if you multiply by 5, basically specialty drugs are $55, $60 per member per year, or per member per month. So that's, each member, an average member would have about $60 in specialty drugs, and it increased to 20% from last year to this year.
So just so that, like, looking apples to apples, if it's close to a 30% increase for Kaiser, it's $6.40. It's
Yes.
still a much lower per member per month on their
Yes,
formula.
it is.
Okay.
Yeah. The specialty drugs, but that is professional specialty drugs. So it's a little bit different. It's not prescription. So prescription rheumatoid arthritis drugs you get through your PBM essentially. You typically don't get those through the doctor. So the doctor's administering these Kaiser drugs, and it's like chemotherapy, those sorts of things. So it's a different category. So it's a different category. But overall, the specialty drugs for Kaiser is definitely lower. I'd have to look up the exact number.
Okay, got it.
To compare.
I see that distinction. Thanks.
Yeah. Sorry. Yeah, there's various categories of specialty drugs. Especially, let's move to the next slide, actually. Where pharmacy trends. So we do have different categories of drugs here. So overall, the total drugs on a per member per year basis is about 10.1%. Non-specialty drugs, so your typical, just brand and generics, increasing 8%. The specialty drugs, especially, with the self-insured plans, it is increasing almost 16%. The medical professional, so those are specialty drugs that are administered in physician's office. That's actually a small decrease comparatively. But the outpatient facility, so when you go in for, and some of those tend to be a little bit higher cost, of really, really novelty drugs that Dr. O'Neill is kind of talking about. Some of those, let's just say Zolgensma, some SMA, and some of the really high cost, like gene therapies and stuff like that that are classified as specialty drugs, those have been increasing about 17%. So, but the biggest cost driver, at least in terms of total dollars, is really that specialty drug, the PBM specialty drug increases, which is, which makes up actually not quite the majority, but a large chunk of your overall drug cost. Next slide. So some of the PBM drugs and the cost drivers. And so you can see the increases or the changes there on the right, but this is by um, the overall allowed cost for a drug during the most recent 12 months time period. So the drug that was had the most cost overall for PEB was Humira. And so that actually, there was about a $1.6 million increase overall. 8.5% was really due to the allowed amount, and 3% due to utilization. So overall, it just kind of keeps increasing for Humira. Stelara, the cost also increases about, I think, 30% total. 20% of it's due to increased utilization. Ozempic, you can see there is the number 3 drug. So people are using this for the diabetes. Overall costs about almost $8 million. And that is an increase of almost roughly 50% compared to the prior time period. And then the next few drugs, again, immunosuppressants, some names probably seen on TV or remember, those are all impactful. So a lot of the drugs, you probably recognize it from the ads that you've seen, and you can see how the costs are increasing, not only in unit cost, but utilization. So people see those drugs, they go to their doctor and get prescribed it, and the costs keep increasing for PEB. And so overall, a lot of specialty drugs, well-known specialty drugs that keep increasing the cost. Next slide. Medical pharmacy. Some of these names are going to be much more difficult. They aren't advertised as much, but lots of higher cost drugs here. Some bigger changes across the board. Some utilization increases, some utilization decreases. A little bit more messy. I don't know if there's anything that's really outstanding. I think maybe that Keytruda has been increasing, and Trevo, so that's 8 and 9. But some decreases there and some increases. It's just kind of like all over the map, as we have very few utilizers for a lot of these drugs. So it can be very volatile as members use or stop using these drugs. So those can go up and down. Next slide. This next section, we're going to take a look at the risk of the population. So the risk scores that I mentioned earlier, the proxy for how much you would expect a member to cost, as well as the efficiency of the plans. Basically, how well are the plans managing that risk of the member, and in terms of the dollars per essentially per risk unit for each of those members. But overall, as mentioned earlier, risk has increased about 1.2% across the PEB from prior year to this year. We do normalize to the prior year time period. So you can see, based on total PEB, it was 1.0. You can see the relative riskiness of the members in each of those plans. So there on the left, you have the Kaiser deductible and Kaiser HMO, and their risk scores are both below 1.0. So they are, based on the diagnoses, healthier than the average PEB member. So the average Kaiser member is healthier than the average PEB member. And you can see the Kaiser deductible is even much more healthy. So you have some selection going on there, where the really healthy members who want to be in the Kaiser plan are signing up for Kaiser deductible and getting that 1 or 3% contribution and paying a little bit more and pocket costs, but getting that coverage through Kaiser. And, it's just healthier members there. The three MOTA, Providence, and statewide self-insured plans, generally, those are at PEB, average PEB risk or higher. Statewide does have the highest risk, about 8% higher on average than PEB. MOTA has the second highest risk, and there was a bit of an increase, moving from 1.01 to 1.04, so about 3% increase in the MOTA risk. Providence Choice did have increases as well, but their risk still is a little bit below the average PEB member in this case. Next slide. Taking a look at those risks and the cost of the member, what we do is try to see essentially how efficient a plan is. So what we do is we take the overall cost, including admin rebates, and then essentially normalize it to a 1.0 member. So basically, if you have a higher cost member, that will bring down your cost because you're expected to spend more to care for that higher risk member. For the lower risk member, we would increase your costs because that lower risk member should be less costly. But what we want to do is we want to take a look at, if you had an average PEB member, how much would that member cost in each of these plans? And this is based on the paid amount. So after member cost sharing, so Kaiser HMO, does have a richer plan, so that does add to their cost. But overall, when we normalize to 1.0, it looks like MOTA is maybe the most efficient plan out there. For that 1.0 risk member, they have the lowest cost at about $527 per member per month. Providence Choice is $570. Statewide is actually a little bit lower at $565. And then you have the Kaiser plans, which are above $600. So overall, it does, even though the costs may be increasing a bit more on self-insured plans, the efficiency, the cost of that member on those plans might be a little bit lower in this case. Next slide, please. So taking a deeper dive into some of the clinical conditions. So this first slide looks at the top conditions, clinical conditions, and the types of services that the members are using. So for overall, the number one spend is for preventive and health, other PCP visits. So generally, I think that's good. You are not having certain conditions really standing out. It's really people getting their preventive and typical services. Pregnancy is the number 3, although it kind of like mixes with essentially like colds and other conditions there. But pregnancy is number 2. And then you have arthropathies, joint disorders, so knees, hips, those sorts of things as number 4. Depression services, mental health services is 5, and then arthritis, which has some of those specialty drugs applied. But overall, pregnancy is typically a big cost for PEB. The joint disorders, in the IWG, we're working on the COE to help offset some of those costs. But number 5, that's a huge one that's been increasing for PEB. You can see it was number 7 prior, now it's number 5. Increases went from like 22 to 26 million, so over 10% increase in cost. Services for mental health services. I think working and just trying to ensure that people have the right to coverage or have ability to go get coverage to find that provider, because those mental health services are, increasing greatly, is a much bigger need over prior years, and just making sure that the members are having the services that they need, finding those providers to help them with their mental health issues. Next slide, please. Another look at clinical conditions instead of by dollars. This is by utilization. And then we have the increase of members with that clinical condition there on the right. The biggest increases are, in this case, obesity. So obesity treatment, as you can see, is increasing about 25% almost across the board. MOTA has actually a small much smaller increase, but for Kaiser, Providence, and statewide, it is 20% increases in members getting treatment for obesity in this case. Diabetes, again, those, some bigger increases there as well. And then the section above it, respiratory, there are some bigger increases for respiratory. Some of that may be due to RSV and COVID, but it is a higher increase in this case. There are some other services with smaller utilization. Some of the bigger ones like hypertension, I think mixed across the board, some decreases, but small increases there. And then mental health services, the number of members getting that prevalence hasn't changed that much, but I think people are getting more services, so they might be getting their treatments more continuous, and that's good news. But the number of services are increasing, but it's, and also for members as well. But overall, I think really the obesity, it continues to be a big one. I think for inpatient services, bariatric surgery has actually increased by about 20-something% as well. So not just, with people wanting to get Ozempic, the surgical intervention for obesity also has been increasing, at least in the most recent time period. Next slide. Preventive screening rates. This is one area where PEBB has been relatively steady, but unfortunately steady is below what we see in our book of business for preventive screenings. So there on the left, we have employee and spouse preventive visits, and you can see they're below the book of business and have been below the book of business for quite a while. There was a little bit of a drop during COVID, but the rebound, hasn't been beyond. So it's kind of staying at that 25 to 28% rate, which is below what we typically see. Better news on the colon cancer screening. There on the right, it is above the book of business. Breast cancer is about at the book of business. Cervical's below, in this case, and has been below, and cholesterol's been below. So overall, preventive services are not quite where we see for book of business. So there might be, I think we've seen this for quite a while. And we keep talking about trying to get members to get their preventive services. It's just another area that still needs to have a little bit more of a return to services or increase in utilization. Next slide. Just going into a little bit more detail by the different types of services. Inpatient, as mentioned earlier, there's not much change in the inpatient, actually a small decrease overall. Outpatient unit cost, as I mentioned earlier, is increasing, and that's causing some upward pressure. And hearing the contracting issues, that's probably not going to be somewhere that's going to get some relief anytime soon. This third one on emergency room usage, when we go through on that slide, there has been increases in utilization, and a lot of them are for the lower intensity or non-emergent usage. There was a big decrease during the COVID time period as people didn't want to go into the emergency room because they were worried about getting COVID from those members, other people in the emergency rooms. I guess that worry has gone away, and utilization of emergency room is increasing quite a bit, and maybe not for services that really should be seen in the emergency room. So that's one area where cost pressures there might be able to be some changes, some things done to reduce the cost pressure of emergency room usage in this case. Lab and radiology costs have decreased quite a bit for lab because of COVID, lab services not being used anymore. And then prescription drugs, I think we've talked about this quite a bit, just especially drugs again, Ozempic. But a little bit more detail on the next slide on inpatient facility. So the admits per 1,000 utilization has not changed much. It's actually dropped a little bit. For Kaiser deductible, the admits did increase a bit, but most of the others did see a small decrease. And then the allowed amount per admit actually has been relatively flat or slightly decreased. So cost increases aren't as much. Types of service admits hasn't changed significantly and hasn't been too many really large claimants in this case. But overall, at inpatient facility costs are a little bit of a decrease. And as mentioned earlier, obesity surgeries have increased quite a bit, 26% over the prior time period. Next slide. Outpatient office visits. Office visits have dropped, probably some due to fewer COVID office visits and vaccinations. But the cost per office visit's increasing quite a bit, 8.7%. Allowed costs for established patient visits, like the different ones, the 15, 30, and so on minutes, they are increasing about 6 to 8% on a per service basis. So the upward cost pressures are happening at least on the office visits. So this is one area where we want to keep in mind and keep looking at if the costs for professional services keep increasing by 6 to 8%. That's obviously, a big service, at least in terms of number of visits and utilization, and that will increase the cost for PEB as those unit costs increase. And then there's one pneumococcal vaccines. That's actually kind of new. Medicare just started covering it recently. And so those are showing up, and they are a pretty expensive vaccine, over $300 per visit, but those increases are increasing quite a bit at least. And we'll see where they go, at least in the next year or two. But it's a new covered service that's been increasing the cost for office visits. Next slide. Emergency room. So while the cost per visit is flat, the number of visits is increasing 7%. And so there's that rebound of services for emergency department visits after COVID. It continues to return. Visits continue to increase. As you can see, Kaiser Deductible had a big increase. Providence Choice had the smallest increase of 3%, but overall visits are increasing 7%. The intensity level, we had talked about potentially intensity level of visits, like how serious that emergency room visit, those had been increasing, which made the loud amount per visit increase quite a bit. That's not happening. We are going to the lower intensity services that are increasing the most. So non-emergent visits as classified by NYU. So basically the percentage of overall emergency room visits that might, really are not emergent, not really necessarily should be seen in the emergency room. That's increasing from 18 to 20% of your visits. So a lot of people are having more non-emergent visits. And so trying to attack that may be one way to help save money in the next few years for PEB. Next slide, please. Lab services, these are decreases mostly due to COVID, some savings there, as mentioned earlier. Next slide. Radiology, utilization's increasing a little bit, cost hasn't increased very much. Some interesting services that might have changed utilization of this one, radiation therapy is increasing, but the cost per service varies quite a bit depending on where you go, from $300 to $2,500. So it's one potentially site of service. Sean Parkman's not here, but site of service is one of his biggest areas he wants to target. But there are potentially ways of directing people to maybe lower cost providers that might be helpful in terms of keeping down future costs as you go to some maybe lower cost providers that are just as good. Next slide. And then prescription drugs, loud amounts continue to increase. This number of scripts hasn't, so that means the cost per script's increasing based on specialty drugs. We'll talk about this quite a bit, so I'll just move on to the next slide. Loud per brand, excluding specialty, continues to increase. Some of that is Ozempic. Ozempic is a not specialty, at least that's how it's classified in the database. So that does have an impact on the loud per brand cost here. Good news, generic utilization has been increasing, but some of it's due to fewer COVID-19 vaccines. COVID-19 vaccines were brand that dropped down the generic utilization, but overall, generic utilization is coming back. Hopefully, we will see that continue to rise as more drugs drop off of, become generic, and hopefully that will save some money for PEB. Next slide. And then specialty drugs, again, costs increasing in the terms of the allowed per script and the number of utilizers of specialty drugs. So a big driver of the cost. Allowed cost increase for PEB was 2.8%. Without specialty, it would have been 1.1%. So 1.5, almost 1.7% of your cost increase is just due to specialty drugs. So a big driver of PEB's cost per year. Next slide, please. So just kind of talking about potential areas to focus for the renewal and the future. Mental health services, I think we've talked about this. Trying to find set standards for mental health providers and access. I think there's definitely ways to do that. We're trying to address that in the renewals and potentially through the IWG as well. So hopefully that will help those members who need mental health services find those providers and not have to have issues with calling up providers that aren't taking new patients and stuff like that. Social determinants of health, it's tied into that behavioral health services. Those with SDOH have higher intensity BH needs. I think that's an area where we're going to keep trying to look into for utilization reports, but trying to help those higher cost members find the services and keep their costs down and address their needs is of importance, especially with health equity and PEB. Next slide. Diabetes, I think we've talked about this in terms of prevention, wellness, and then the high cost drugs, especially PBM. Again, we've talked a lot about this, and then the rising costs. The contracting, it's something that was increasing during last year. We keep hearing about the contracts, providers wanting to have higher rates. Something that we're going to have to address or take a look at and hopefully manage in this renewal process and maybe in RFP to try to keep those costs down so that 3.4% is going to be easier to meet for PEB. The 200% of Medicare does help put a limit on some of those services, but it's not for all the services. Professional services are increasing quite a bit, and managing those costs, those unit costs, is going to be very important, at least to meet that 3.4% going forward. And that, I believe, is the last slide. Any questions or comments?
So just a comment that I know what's next on our agenda is the primer for our renewal process. We're going to take a break before that, and we're going to want to keep all of this information in mind throughout the renewal process, both what our utilization looks like and where we're seeing trends as we make any changes to health plans. So a lot to digest. I know we'll be referring back to it, and just want to see if we have any last questions before we take a break. And also want to recognize Dawn has joined us. Welcome, Dawn.
Good morning. Thank you. Hi, everybody. Sorry I'm late. Thank you, Emery. That was useful. And I'm sorry I came in the middle. One of the slides had an important question, though. For me, you said that there was variability by provider of the same service delivery and by an order of magnitude, not by a small amount. It is of interest to me how we can support, one, making sure that the service, even if it's coded the same, is the same service that's varying so dramatically and not a different medication, for example, with the same service code, but a vastly different medication that a different provider uses. Some of those kinds of details, but shifting utilization to lower cost providers who are meeting quality goals and also going upstream seems to happen at the same time. For example, doulas who are both upstream and they are a lower cost provider and they increase the quality of care and decrease the kinds of health outcomes that result in increased utilization down the line. So those are questions I look forward to exploring in the next phases. Thank you very much for the presentation.
Yeah, and I think we've talked about this with the PEB board in the past, and this is an area that I think we've want to potentially explore an RFP. We've done like RFIs on like advocacy, right? On advocacy vendors like not care management, but member services that if you first point of contact that they might be able to help find providers, lower cost, high quality providers that they can help direct members to like to help them find that lower cost provider that can manage the conditions and stuff like that. I think that is one area where it's on as a a bridge a strategy for PEB. I think in the renewal primer, it's like we have a list of potential ways of strategies to help reduce costs long term, and advocacy and members advocacy to help members is one of them. And that's one area where where we do have if we do have this variability in cost, especially in maybe in like certain areas, like the metro area or down the I-5 corridor where there is choice in providers. How do we get members to realize that maybe their current provider or that there's another provider that could be providing the same service at that's high quality at a lower cost, and directing that to them? That's one way to help save money in the future and without really hopefully annoying the member too much, being too mean to the member. But it's just those sorts of solutions, just potential ways, a program that could be added or like looked into to help PEB in the future. And we've I think we'll want to definitely explore it for the RFP. We've done RFIs on it. It keeps changing, it keeps improving, data keeps improving, and so various we'll work on it. We don't have the solution right now, but we can definitely work on it for PEB.
I think there's the approach of how the carriers are managing the quality within their network for consistent performance about care delivery. And then as you brought up with models of care that like include doulas in care of pregnant population and postpartum population, there's looking at practices that have that array of services. So there's slightly different strategies, but both would have the kind of impact that Emery's discussing.
Thank you.
All right, well, thank you. And with that, we will be on break for the next 10 minutes. I'll put in the chat. We'll go ahead and go until 10:48. Thanks, everyone. See you in 10 minutes. All right, well, welcome back from break, everyone. We are running ahead of schedule, which is good. It means we should be able to end ahead of schedule as well. And want to make sure people ask their questions during the annual renewal primer. And we've got Andrew and Emery leading that for us. So I want to double check. We know Emery's here. I saw Andrew in the chat earlier. There you are, Andrew.
There I am.
Are you both ready? I'll turn it over to you.
We are ready. Thank you, Siobhan. Good morning, everyone. Glad to be with you today, and to be here kicking off the 2025 renewal process and discussion in earnest. And so this will be the first of many meetings on this topic. The way that we've organized this portion of the discussion is in 3 sections, the first of which is around current state. And so we will take a look at PEBB's current state from a few different perspectives. We'll then transition and talk about what we're seeing in the market more generally in terms of macro trends and other topics that are applicable for PEBB. And then in the final section, we'll talk about planning for 2025. We'll go through the cadence of these meetings and discussions, and sort of get you oriented, as this will be a big focus point over the next 4 or 5 months. Okay. So I think we can advance 2 slides. Thank you. And so as we do with these renewal meetings, we do start with PEBB's vision for healthcare, which you can see in that pink square. This is, of course, embedded within the governor's priorities around healthcare. Governor Kotek's been in office for a year now. A big focus has been made on behavioral health, addressing health inequities, both topics that are also key strategies for PEBB, so great alignment there. One component of this vision that we did want to spend a little bit of time talking about today is this idea around reliance on evidence-based medicine. And so in some previous board meetings, board members have given voice to some of the limitations around overly relying on evidence-based medicine. There are some inherent biases around who's doing the research, who's participating in the research, and some other variables that sort of inadvertently can perpetuate health inequities. And so we have taken the liberty to update PEBB's health equity strategic pillars to sort of reflect on this limitation. And so if we can flip to the next slide, we can spend a minute talking about that. And before I do that, I'll just reorient everyone. This is the strategic pillars. This is a framework developed by PEBB to assist in centering decision-making within equity. And so this is a hugely useful framework during this time of year as we're talking about renewal decisions. And so this framework combined with the Health Equity Committee are both hugely valuable throughout this renewal process to ensure that health equity issues are sort of being considered so that we're adequately informing board members so that you can make decisions for 2025. And so with that said, the statement that we've added, we've put a little blue star by it. And it's really to reflect on the dynamic that I just went through around sort of inherent biases and over-reliance on air quote evidence-based medicine. And the idea is not to throw out evidence-based medicine. The intent here is to sort of broaden the definition of evidence to include things like community-based participatory research. And so what we've done, in addition to adding this statement on these pillars, our Health Equity Committee has some work that's in flight to update their health equity screening tool to incorporate some of these other definitions of evidence, including community-based participatory research, to provide a more fully rounded perspective to, again, ultimately most adequately inform board members as you're making decisions for 2025. And so that work is really in flight. And so the intent of our bringing it up today is really to inform you all that this work is underway. We did include a slide in the appendix, which provides a little bit more detail on the work that's underway with the Health Equity Committee. but would welcome any questions or thought at this point, but just know that this work is in progress, and so there'll be more to come as it sort of gets fleshed out.
Andrew, so I just want to recognize this is something that board members have brought up and discussed. We haven't specifically, looked at language here. I appreciate the language here. I don't know if other board members want to comment on it. Go ahead, Dawn.
Thank you. Thank you for bringing this issue into focus here. I am interested in working with the team to do a little wordsmithing around objectivity and subjectivity. And I want to acknowledge that the goal of evidence generation prioritizes the value of objectivity, but the limitations of its implementation lead to perpetuation of those inequities in that way. Thank you for bringing this and acknowledging community-based participatory research, or CBPR, as an important potential mitigating body of evidence that intentionally engages the most highly impacted communities to help define the research questions and come to answers by way of inclusive methods.
Yeah, thanks, Don. That's well said, and we will make note of that and work with you to wordsmith this a little bit and see if we can get a little bit more refined.
I think it's important to remember that evidence, the classic clinical evidence, is based on studying a population that usually has a single problem. So individual variation of any kind is often excluded. We also have the problem of who that basic population is to begin with research, but there's pretty wide-ranging problems if you have a lot of orthodoxy about sticking with an evidence-based result. So I think that the community and population-based approach is super important.
Thanks, Doc. I agree. It also depends quite a lot on who's doing the research and what biases we bring to it and what we're looking for.
Right, and how controlled every variable is and all kinds of not natural things, as it turns out.
Right. Thank you.
Okay, I think we can advance to the next slide, which outlines some of PEBB's established long-term goals, which oh,
can we
yes.
pause for a
I see
moment? It
him.
looks like Emily wanted to make a comment or ask a question. Go ahead, Emily.
Yeah, thanks, Siobhan. Sorry, not so quick with the hand, but I just echoed some of the sentiments of the last two presenters and appreciate the movement towards community-based participatory research, being inclusive of that. And for sure, it matters who's doing the research and who's participating in the research studies in terms of that evidence base. And we do know that it's mostly white males actually that are participating in those studies and not women or women of color or people of color or tribes. And so because of a lot of historic challenges with medical research, Tuskegee just mentioned, and so I also, though, wanted to make sure that the evidence base is not just specific to Western health and healing. And so there is a lot of evidence base, for example, in Asian communities or cultures. And so just Canada, just want to be inclusive of, going beyond the borders of the US and looking at other evidence base as well. So, but I think this is a great direction. So thank you for those who worked on this.
Yeah, and these are all great thoughts, and are going to help us sort of continue to develop out the incorporation of some of these other definitions of evidence. So thank you for sharing those. And we're really lucky to have the Health Equity Committee that is constantly trying to address things like this and bring them forward to us. And so I just want to give a shout out to that collaborative group that is just hugely valuable, especially during the renewal process, but really throughout the year. And the work that they do really informs a lot of the perspective that ultimately we bring to the board. Any other comments on that before we move on? I'm not seeing any hands, so I'm going to proceed, but just jump in if something comes to you. With this slide, we've got the long-term PEB goals as established by the board 2 years ago in the retreat. And so this is a good time to bring these forward since these are goals that we largely try to tackle through the renewal process. And ultimately, with the goal to advance PEB's vision of healthcare. And so some of these goals are focusing on behavioral health, health equity, focusing on whole person, addressing the needs of a diverse population, ensuring the richness of the benefit, while also managing costs and ensuring affordability on behalf of PEB members. And so these goals attempt to strike a balance between, on the one hand, being specific, and on the other hand, being high level enough, because they are big goals and there's really a lot of sub goals within each of these. I think we can advance to the next slide, which provides an overview of the PEB benefit partners that we're going to be working with as we look to renew the programs 1/1/25. Some of these benefits are not renewing 1/1/25. We've added a little pink star next to those, either due to multi-year rate guarantees or just the nature of the contract, which is more of an ongoing agreement. And so those 3 carriers are the Standard, Unum, and Canopy. But other than that, we will be discussing all the benefits and all of the other benefit vendor partners over the next 5 months or so. Okay, I think Emery, I'm going to hand it off to you to take us through a couple of slides here.
Sure. Thanks, Andrew. So taking a look at what we did in 2024, the composite rate did come in below the 3.4% limitation. So there was a surplus after all of the plan changes and the renewals. PEB added the funding assessment to get up to the 3.4%, but came in below, and that's going to help out a little bit for the 2025 renewal process. So we do have the medical and prescription drug, the medical plan increases there. Statewide came in at about 4.3%. It would have been a little bit lower, but you did add massage therapy as a benefit. Choice came in at 6.5. MODA came in at 5.9, but the PEB board did elect to essentially time down to low cost plan status. So they did come in a little bit below that 5.9, and Kaiser came in at 13.2%. There were definitely, as mentioned, some plan design changes to help increase behavioral health access. And, when some other things, we want to address the care gaps and increase, enhance the benefit as we can and manage the cost. And some of those things, in terms that we did look at, we are continuing to look at Ozempic, obviously, or weight loss drugs is one of the bigger ones. And that's some of the process that's going on nowadays. Next slide. Taking a look at just some demographic information for PEB, we have various little boxes here. So in terms of the plans, the choice plan there in the top left has the most enrollment. It's actually at 32% of the medical enrollment for PEB overall. Statewide, at 29%, and in MODA and Kaiser basically at about 20%. For dental, pretty much the majority are in the MODA or the dental plan of Oregon. Kaiser has about 12%, and Willamette Dental Group has 21%. So the majority are in the self-insured plan for dental. The other information on the demographics, just kind of keeping in mind the top 5 counties, Marion's the biggest, as to be expected. Lane and Multnomah are next to, and then Benton and Polk actually have a considerable enrollment for PEB. PEB is mostly female, 57% female, and the average employee age is actually 46. And then taking a look at a little bit more of a breakdown down in the bottom right-hand corner, the breakdown, 37% millennials, 43% Gen X, and then 70% boomers. And so you can see the ages. It's kind of nice little bell curve there where everyone, well, not everyone, but the majority are between 35 and 54 here, with a few more in the 55 to 64% age group, and some who are working beyond age 65. So overall, PEB is more female, and obviously centered kind of more down I-5 corridor, with some in the metro area in this case. The next slide, please. The growth of costs overall, how does PEB compare to what the medical costs have been nationally? And this slide kind of shows the history of PEB, which is in the pink, and good for PEB. It's the low one. So, if you take a look at the cost increases, they've been generally at 3.4% or below. There's 2 years where it did increase above the 3.4%. In 2017, it actually increased 3.6, but in 2020 increased 4.9. However, for 2020, there was a 2% provider tax that was added and not part of the 3.4% limitation. So you actually did meet that 3.4% limitation with the if you take out the provider tax. So overall, if PEB has been coming in below that 3.4%, which has helped build up the stabilization fund and keep PEB healthy, and has been running better than what we've seen nationally. So the blue line at the top is what Mercer has seen nationally for cost increases. Over the last 4 years, it has been about 4 to 6%, and that's after plan design changes. So, as PEB has not made significant cost reductions in plan design changes and actually has added some benefits, you've actually essentially outperformed what we've seen nationally. So as mentioned earlier, the national trends are, 6 to 7% after plan design changes. That gets you down to about 5%. And PEB has done better than that at 2.9%. And the cost of PEB actually has been lower than the overall inflation rate and what workers' earned salaries are. So essentially the value of PEB is actually greater to the members, as the contributions remain lower than what their salaries are increasing and what inflation is. So kudos to keeping the plan running well over the past, I don't know, 10 plus years. Next slide, please. This is a new slide where we kind of melded a few things together. In the utilization report, we talked about efficiency. So how well are the plans running? How well are they managing the risk of the member? This takes that concept and kind of breaks it out into various components. What we have is we're taking a look at the risk-adjusted cost, allowed cost per member for medical and pharmacy, as well as the admin rate that is charged by the plans. And what we're doing is we're comparing them to PEB on average. So the bars show how well a plan is performing compared to PEB average. We break it out into medical contracting, and the medical contracting is based on some of the work we're doing in the IWG, where we have the medical costs as a percent of Medicare. So based on that information, we can see essentially how, relative to Medicare, how well a plan is contracting, how much are they paying the providers on the unit costs. And then what we do for the rest of it, medical management, essentially the difference between the contracting and the rest of the risk-adjusted medical The pharmacy is all just essentially the risk-adjusted cost compared to PEB average, and then you have the admin, which is their cost per member compared to PEB average. For Kaiser, we do add in integrated care management fees as part of the med contracting. You could argue it could be part of the medical management, but we would be just shifting essentially dollars from one column to the next. And what this tells us or shows us is that based on the July 22 to June 23 claims information, that MODA is essentially performing the best, saving about $57 per member per month compared to PEB average. Providence is pretty close to PEB average, and Kaiser is more costly than PEB average. And so this is kind of similar information to what you saw on the utilization report in terms of efficiency. But how they're doing it is I don't know, a little bit interesting to me, at least. Hopefully it's interesting to you. But in terms of MODA, a large portion of their savings is really due to the medical contracting. So taking a look at the percent of Medicare contracting rates, they're actually saving $45 per member based on their contracted rates. And then their management of medical, essentially the difference of overall medical costs, is another $22. The prescription drugs for MODA ends up being a bit more costly per risk. So that's about $7 per member, and the admin fees is a little bit higher. But overall, that gets you to a $57 savings compared to PEB average. For Providence, the contracting is basically right at PEB average. The management's a little bit more expensive, but the prescription drugs and admin are essentially, again, at PEB average. So essentially, Providence is your average plan. But taking a look at Kaiser, as you can see, the prescription drugs do provide some savings, but the admin fee is a little bit higher. And then in terms of medical costs, they are higher. Part of it may be due to the integrated care fees and how well that's doing for the medical management. So right now, the integrated care fees and the contracting we're showing it as being more expensive. So essentially, Kaiser's about $49 more expensive per member per month on average for PEB member, and most of it's due to their contracting, so their rates or the fees associated with those. So essentially, in terms of efficiency, this kind of takes the, how efficient the plan is in terms of where they're potentially outperforming compared to the rest of the plans. So with that, just kind of leave it up for any thoughts or questions. Emily?
Should I go
Go ahead,
ahead
Emily.
and ask?
Yeah, yes,
okay.
please,
Okay.
please go ahead.
Sorry,
And
I didn't hear.
Yeah,
didn't
and
hear
my
if
internet's
anyone-
unstable, so I'm off video
Oh.
for now, but I see you and then Representative Nose, I believe, raised his hand as well.
Okay. I actually just had a follow-up question about the Oregon PEB's current state slide. Thank you for doing that slide and breaking it up by top counties. I was surprised to see Lane County was number 2 before Multnomah County and others. And so I'm just thinking about the hospital that closed recently in the Lane County. Is it Peace Health or just, I haven't been so involved. But I think thinking about how the hospital closing might impact, things in Lane County, our members in Lane County moving forward. So didn't know if anybody had any thoughts on that.
Yeah, I haven't heard anything about how that's going to be impacting or has impacted. I think we'll want to definitely take it back to see if there's any actions. I mean, you are being asked to go to Springfield, which is, depending on where you're living, it could be a little bit more impactful, but it's not that many miles, but we'll see in terms of capacity, contracting, other issues, having 2 hospitals pretty close. I don't know. I mean, they were both Peace Health, so, but we'll have to find out and get back to you on that.
Okay, thanks.
Representative?
Okay, thank you. So I am struck by, I feel like this has been a very positive meeting overall in terms of PEB, how we're doing. Yeah, we have some challenges, but we have the same challenges that every other plan is sort of facing. And I feel like in the decade that I've really been around this, periodically we have come up for criticism because we have a rich benefit plan, but I feel like we're managing it here very well, or this at least would show that we are. And so is there something that we're doing that like I should be telling other plans? Because like we have a rich plan, it's actually doing well, and we have periodically taken pot shots for that, but like we're managing our costs. Like, is there something like what's unusual? This feels unusual to me in a good way, and I'm trying to understand it, I guess. It's maybe what I'm trying to get someone to tell me at the 1,000-foot level.
Yeah, I there I don't know. To properly answer that, I don't know if we want to go off the cuff for it.
Well, I mean, I go off the cuff all the time.
We can go off the cuff. I
you
know.
know,
It's just like, I do think, I don't know, some things that have struck me working with PEB over all these years. I think the board is actually has been very, very collaborative and working together, and their vision has been pretty unified over time. I mean, I think everyone is very interested and definitely wants to keep the best for the members and understand that and keep that vision as they're even, when there has to be some adjustments made, keeping that vision for the plan and just trying to find where you can deficiencies. And I think a little bit here, a little bit there keeps helping all over time. And I don't know. It has been very good for a long time, keeping to a 3.4% limitation. That's well below, what we see typically. I don't know. That's something that's kind of struck me in terms of working with different clients. It's just like, it's not reactionary. It's like, it's definitely more forward thinking and just understanding and like, okay, what can we do? And just working towards that goal. Ollie?
Yeah, I would just echo what you said, Emery. And, we do have really good partnerships with our plans. And I think they do a lot of things that you don't necessarily see on some of the slides that, as far as like helping members, advocacy solutions. I think that, there's investments that our plans make to really make their plans more efficient. And I think we manage pretty tight plans as well. But I think there's legislation that's helped us as well, to be totally candid. So yeah.
Oh, yes. Okay. All right. So some of the hospital reimbursement stuff that we've done.
Yeah.
I believe I voted for that bill. Okay.
Credit where
going back
credit
on
is
mute.
due, Rev knows.
What?
Credit where credit is due. Thank you.
Well, once in a while, yes. I mean, Emery, I think, were you the consultant when I was on this board for real back in 2014?
Yep.
Yeah. Okay. Hopefully you're going to help this group design a better procurement process, because I am not participating in that. Okay. That was hell.
Well, yeah, I guess it is. You've put me on notice. Okay. Yeah. Okay. Well, if any other comments, if not, we can move on to the next section.
I'd like to respond there for a moment and acknowledge that when Rep Nose just now said, it looks like we're doing a great job. How are we doing a great job? And what are our talking points about that? I heard some crickets in places where I wish I had some smarter things to say. So I'd like for us to think about that a little bit for next time.
There's so many things that you're doing well.
I mean, again, I just
too
think like when I think about collective bargaining, health insurance plans, everything I hear, I mean, we are I got to tell you, everywhere else in this state, it's like hanging on for dear life to hold on to a good benefit. And it just feels like we have been able to do that and buck the trend. And I'm looking for some, and if it really is just that we capped hospital costs, okay, that would be good to know. I mean, like, but things that, like, as a policymaker, I should be exporting to other parts of this state to say, hey, you should look at some of this stuff.
We can definitely provide talking points, Rep knows.
Yeah, I mean, there's no rush.
Yeah.
I mean, like, I got, but
Yeah, I don't want to jinx our renewals coming in a week with too much
Okay.
sunshine, but yeah.
We do have a couple of slides in this section too, which kind of speak to what Emery was talking about, where we'll show you what other plan sponsors are doing with regards to their benefit strategies. We've included a column for PEBB, and PEBB is largely sort of doing all of them to some extent, whereas a lot of smaller plan sponsors will have to prioritize and pick and choose. So there is sort of a cumulative effect when we're able to look at all those different strategies. So we'll get there in a second, but just to kick off this section, this is a little bit of a gear shift, and this section really talks about market trends that we're seeing, and we've tried to sort of curate this section based on applicability for PEBB. And so this first slide is probably the highest level, and this calls out these 5 macro trends, which is that text on the left, and then on the right are some statements around what plan sponsors can do within each of those. Trends. And so the first one around looming financial challenges, obviously, there's lots of uncertainties within the broader economy. There's a little federal election happening later this year, which always has an impact. Inflation is continuing to sort of play out, which, obviously medical inflation is a real thing that we've been navigating over the past few years and will continue to do so with this renewal. And then specific to healthcare, Emery spent some time talking about, these $1 million drugs that are hitting the market. And there's a pipeline full of more $1 million drugs that are going to be hitting the market. And so, the challenge for plan sponsors there is to understand, how those drugs are going to impact member outcomes and of course, try to budget for them. The next one's around shifting employee priorities. There's been a lot of disruption in the labor market from 2022 through current. More so than we've seen a couple of years ago, employees are starting to prioritize different things. They're starting to prioritize well-being and flexibility within their work lives. And so it's really important for plan sponsors to understand what are the priorities within the employees and members within their population. And so, one of the efforts that we'll be kicking off here in the next few months is a well-being survey that we're gonna ask PEBB members to complete, so that we can understand what their priorities are with regards to their vision for well-being for themselves and how PEBB can support that. We do have some survey data in this section, which is not PEBB specific, which can be interesting to look at and try to determine to what extent it's applicable for the PEBB membership, but there's really no replacing a PEBB specific survey. And so, we do surveys like this every so often, once or twice a year, sort of focusing on different topics. The next one around supply and demand challenges is specific to healthcare. Obviously we've been talking about provider shortages for some time with you all. This is not a dynamic that is unique to Oregon. When we've tried to solve for some of these shortages, it can potentially lead to some innovative solutions, which is great. Different ways to try to deliver care that maybe hadn't been contemplated previously. But of course, the converse of that is that we don't want members going without care because they can't find a provider. Obviously, that's not good for their own health outcomes. And so this is a dynamic that we keep keeping an eye on, and we'll keep talking about with you all. The growing role of states in healthcare. PEBB like a lot of plan sponsors, really has membership across the country. And so more so than in prior years, there's this continuing momentum of states passing state-specific legislation. One example is like statutory leave programs, which are all a little bit different in those states that have passed them. And so plan sponsors like PEBB, who have this sort of diverse geographical membership, are trying to think through, how do we provide as consistent of an experience as possible for our members? And then the last macro trend here is around technology. This one could probably be on there every year. Some of this is really nascent, things like artificial intelligence and the role that plays within healthcare delivery. Some of it is maybe a little bit more pedestrian, things like expanding telemedicine to try to move beyond just acute care, which is not as sexy as AI, but is a legitimate shift that continues to happen. And so, understanding the different services that these technologies enable, how it impacts member outcomes, how it impacts PEB's budget are all important things that, like I said, will sort of it will be a recurring topic year over year. Just checking the chat because I saw someone in a comment. Okay, so I think we can move on to the next slide. So affordability. Affordability has been a topic in healthcare for probably as long as I have had a career in healthcare. But every year it sort of becomes a little bit more of a critical issue for your average employee because healthcare costs are rising higher than wages. And so this exhibit here is not PEB specific. This is survey data from employees from across the country who are responding. And so the question posed to these employees is, do you agree with this statement? I am able to afford healthcare that my family and I need without financial hardship. So, no surprise here in the results. As annual salaries go down, respondents are less likely to agree with that statement. Another finding from this survey, which we've called out on the right, is that certain populations are less likely to afford healthcare. Women, members of LGBTQ plus groups as well. And so again, this is not PEB survey data. This is broad data. And so let's flip to the next slide and start to look at how affordability plays out for PEB members. So the first lens that we're going to look at with regards to PEB affordability is around contributions. And so these are the paycheck deductions that are taken out of PEB employees' paychecks to cover medical and dental are the two benefits that we're covering on this slide. And so, we've bumped up PEB data contribution levels against 3 data cuts. Those cuts are government groups with at least 500 employees, Oregon employers with at least 500 employees, and nationwide, any employers with at least 500 employees who have large union participation. And so, as you can see, if you look at PEB's contribution percentages, which are very low, and so the 1%, 3%, 5% for PEB indicates the percent of the total cost that PEB members are having taken out of their paychecks. Those are very low compared to these data cuts here, which is great for PEB members. But these contributions are sort of one of 2 primary components of affordability for employees. The other being out-of-pocket costs when they're actually at the doctor, at the pharmacy. And so if we want to flip to the next slide, we can take a look at that perspective and see how that shakes out with regards to out-of-pocket costs for PEB members when they're actually going to get care. And so to show that, we're showing PEB's actuarial value, again, compared against these 3 data cuts. The actuarial value, which you'll see as a percentage there, 92%, 96% for the PEB plans, respectively, PPO and HMO plans. That is a measure that basically shows how rich is the benefit. And so if you take the 92% actuarial value, that is stating that on average, for members enrolled in that PPO plan, 92% of their healthcare costs are going to be covered by the plan, with the remaining 8% covered by the member at point of service through deductibles, co-insurance, co-pays. And so if you just sort of go left to right and compare PEB against these data cuts, you can see that these are very rich plans. Having a PPO plan in the low 90s, the HMO in the mid to upper 90s, those are very rich plans. And so if you're combining paycheck deductions being very favorable for employees, as well as this actuarial value, which is showing how much members are paying out of pocket. It's a very favorable picture for PEB members compared to frankly most Americans who are getting plans through their employer. Just gonna
And
pause
Andrew,
for any. Yes.
Yeah, I just want to make sure that, so the PPO plan, that's the statewide plan, and the HMO, EPO are the rest of the plans?
Thank
Or
you,
can you
Siobhan.
clarify?
Let me clarify. The PPO is actually the choice plan. And we chose that plan because that is your most heavily enrolled PPO plan. And then on the HMO side, that's the Kaiser traditional plan.
So this doesn't include the statewide?
Correct.
Okay, thanks.
Yep.
The statewide plan is going to be closer to like the 90% or a little bit below 90%.
Thanks. Bear in mind what EPO stands for?
Exclusive provider organization.
Oh, okay, thanks.
Similar to an HMO. Any questions on affordability? Any comments or thoughts before we move on? Okay, so on the next slide, we've taken some survey data based on what other plan sponsors are focusing on related to behavioral health support and what they can provide for their members. And so we've organized this based on these 6 actions have been organized based on their perceived effectiveness by the plan sponsors who have actually taken these actions, which is that middle column, the first purple column. And so for this first one, adding supplemental network for virtual or in-person care, amongst these top behavioral health actions, that's the one that plan sponsors are perceiving the most value. It's also not the easiest action to take, which is why when you compare the percentages in the blue, I'll call it a blue column, the light and dark blue column, not as many plan sponsors have taken that action. Again, because it's a little bit of a higher lift compared to some of these other actions. For example, number 2, which is expanding or enhancing EAP. This one also has been very favorably ranked in terms of effectiveness at 59% highly effective. But if you look at the 69% who've taken that action, that's a higher percentage. It's just a little bit of an easier action to take than expanding a virtual network, which is something that PEB took action on last year with the addition of the Spring Health Network in the MODA plans. Number 3, increasing screenings for mental health and substance use disorder. Obviously, that one is really important to try to identify some of those issues as early as possible and sort of get ahead of them. Is not an action that plan sponsors have taken compared to as often as some of these other actions. And then rounding out the final 3 are manager trainings on recognizing behavioral health issues and steering the resources. Number 5, conducting campaigns to reduce stigma. And number 6, adding digital or in-person resources for managing stress and burnout, building resiliency, that sort of thing. That one often comes in the form of like introducing an app that members can use to sort of self-service address some of those issues around either burnout, stress, some of those kind of lower acuity behavioral health needs. If we want to jump to the next slide, this is another look at what other plan sponsors are doing, but now we're looking at how are they addressing health disparities. And so Rep Notes, in response to your question, and Emery commented on this, and I commented on it as well. You know, when you look at what other plan sponsors are focusing on with regards to tactics and actions in a given area, health disparities, behavioral health, et cetera, you can see in the PEB column that these are actions that are all being looked at for PEB. And that's sort of a luxury that a smaller plan sponsor can't really capitalize on that strategy just because they're smaller. They've got more finite resources. There's more of an exercise in prioritizing actions and choosing those that where you're going to get the most bang for your buck. And so for these top three actions that plan sponsors are taking, probably not going to come as a big surprise to anyone. Collecting employee demographic data, which is obviously important to understand what are the disparities within a given population, and is, you know, a good first step to sort of create an action plan and start trying to solve for those disparities. The next one's around requesting health equity reporting from plans. And then the final one is pushing health plans to include more diverse and culturally competent providers in their network. And so those are all three topics that we talk about, as well as, you know, the other list of actions. The only check mark you're not going to see for PEB is the last item, which is a little bit discouraging when you look at how respondents in the other cuts responded. Some of them are not intentionally trying to address health disparities, but many are. So not seeing any raised hands, so I think we can jump to the next slide. This one is sort of zooming out a little bit. It's not specific to behavioral health or health disparities. It's just looking at what benefit strategies are plan sponsors looking at in the medium to long term. And so again, this is another example where, you know, PEB is really in one way or another addressing each of these strategies. You know, the first, I'll call out a couple. The first is perhaps very obvious, you know, trying to expand access to behavioral health services. This again is not unique to Oregon. This is really an issue really across the country. The third one down, enhancing benefits to improve attraction and retention. I suspect this one is probably because of the labor force wonkiness that we've had over the last few years. And many sort of private sector, but also public plans thinking through how can they sort of delight their members with unique benefits that are tailored to the priorities of that population to, again, retain employees, attract new employees, that sort of thing. The last item, and this is not ordered in any sense of magnitude or like which strategies are being prioritized. As you can see in the last item, affordability. Still a huge focus for employers, huge focus for employees. And so that again is a market trend that really has been around for a long time and continues to be hugely relevant for employees and employers.
I just wanted to, you know, tie this back into our discussion on the strengths of PEB, and I know you all were not meeting Mercer, didn't want to speak off the cuff on it, and there's so many strategies that PEB employs around the quality of healthcare and different. I mean, like, to me, there's no silver bullet. There's many things that PEB is doing to control costs and to keep access, and that access should hopefully come with better health outcomes overall. So just noticing the many strategies.
Yeah, well said. Agree with that. Okay, I think we're a little over time, but Siobhan, I think we still have a little bit of room.
We do. Go ahead.
Okay, great. All right, this is the final section, and this is where sort of the rubber meets the road in terms of planning and what the next few months are going to look like as we work towards renewing benefits for 1/1/25. And so if you want to, thank you, Rose. With this slide, we wanted to call out some of the topics that we've included in the round 1 renewal request to the medical carriers. And so this is not an exhaustive list by any means. for those who were kind enough to review and collaborate with us on those drafts. You know that those drafts of the carriers were many, many pages long. And thank you, carriers, for meeting us there and responding to all those. So I guess the way I would think about looking through this is maybe to glance through the bolded items to get a sense for some of the topics we've included. And just know that we're going to be bringing these forward in a lot more detail when we meet next month to start reviewing the carrier responses. On the next slide, we have tried to visually display what work activity is happening over the first half of the year related to renewals, and then what is the content of the board meetings throughout those months. And so we are expecting the round one renewal request from the medical carriers on Friday of this week. When we meet this time next month, will be our first opportunity to do a deep dive into those responses, with a heavy focus on the medical responses in February. After we have that discussion with you all in February, we will finalize and release the round two renewal requests, send those to the carriers, have them respond. We will present those to you in the subsequent month. And that's sort of how this like iterative process goes. We will start to incorporate some of the non-medical benefits likely in March to give us adequate space in February to really take a deep dive on medical, and then start to incorporate some of the other benefits as well as we move into March, April, and beyond. Our goal is to have final decisions and final rates approved and voted on by the board in the April-May timeframe. And then we have June there if needed. We can certainly get board approval at that time and still hit all the milestones we need to hit to ensure that we're ready for open enrollment, to ensure that we've implemented any new programs, that sort of thing. Okay, the next slide has a lot of the same information that I just went through in a little bit of a different format, a little bit higher level. You can see we've noted in March is where we'll start to pull in some of the non-medical benefits. We'll shoot to have final decisions in April, and have the board vote on final rates in May, with again a little bit of a buffer if needed with June. Throughout this process, we are going to be working with the Health Equity Work Group and Committee, and leaning on them heavily to help them to have them help us evaluate health equity impacts of various decisions. And so that will be the results of all that hard work will be woven into these renewal decks, sort of as needed, depending on the topic.
Really appreciate the overview. We will have a lot of decisions to make in the coming months, and I know a lot of discussions as we contemplate our strategies as we go into 2025. And I believe this was the last slide, correct, Andrew?
It was. Yep.
Okay. So thank you for all that information. And now we're going to hear about the surveys to our PEB members, and we have Cindy and Aaron leading on that. So I'm going to turn it over to them.
Well, now just lost my notes as soon as I did that. Hi, everyone. I'm Cindy Bowman. I think most of you know me, but in case you don't, I am the Director of Operations for both PEB and OEB staff. That means that I work with our systems folks, our benefits folks, and also our communications team. So I just wanted to give a little bit of a background, and then I'm going to let Aaron and Teslin actually is also going to be joining, and they're going to introduce themselves and kind of what their roles are. But I just wanted to kind of give a little background. As you know, each year we do a member survey. We send it out in February because it kind of coincides with the food drive, and we get people to actually participate because our carriers donate $1 for everybody who participates. So it's a win-win for everybody. Anyway, we in the past have asked questions. This is really focused on our benefits staff, and our communications to all of our staff, and not so much outwardly focused. So we've asked a few questions about our vendor partners, but not a ton, and really haven't gotten a lot of quality information. So last year we decided, hey, maybe we want to know more about our providers, both our optional and our medical, dental, vision carriers, and their interaction with our members. So we designed and launched this member survey. It's focused on capturing that member feedback about their interactions. So Erin and Teslin are going to review the results. So I'm not going to spend a lot of time with you, but we're not necessarily going to have time to touch on every question, but they'll cover the highlights. We'll have time for questions, so I'll jump back in. Just before I hand it over to Erin, though, I do want to comment. This is our first shot at it, and we recognize that there's probably a lot of questions that you're going to have interest in that we didn't cover. So whether it's in this meeting or you want to send me an email and give me some feedback, we'd really like to hear what we didn't cover that you'd like us to in our upcoming survey. We'll work on that and launch another one again this summer. So Erin, I'll let you take it from here.
All right, thanks, Cindy. Hi, everyone. So just wanted to confirm that for PEBB's vendor partner survey, we received 4,424 responses from members. And also it's important to keep in mind that the period of time that was being surveyed was January 1st to May 31st. So it was a short 5-month period. And you'll see why that's important later when we talk about particularly medical and dental and vision insurance. But right now on the next, or let's see, I think we're on the same page here, the executive summary. Just wanted to give you some highlights about the different plans. We are going to be focusing on the healthcare plans for today. We did ask some questions about the life insurance and disability plans, but we felt that the information that we're sharing here today would be of most interest to the board. So, but please feel free to ask questions as we go through it, but we should also have time for questions and answers at the end if need be. So from the high level, for the healthcare vendor partners, we found that most respondents used Providence for medical, Delta Dental for dental, and then VSP for vision, obviously. Most respondents were generally satisfied with costs, but the most negatively rated category around costs was out-of-pocket costs, and this applied on both or on all the medical, dental, and vision plans. Respondents are generally satisfied with communications and customer service from their vendor partners. And then you'll see for medical and dental that most respondents had not yet likely used those services this year. So in terms of care received from providers, most respondents were receiving care every few months. They had generally positive experiences, and they were likely to recommend their providers to someone else. Around telehealth, not many respondents had actually used the telehealth features, but those who had used it were satisfied with the service and they found the quality of care to be good. They also responded that they were never or rarely concerned about their privacy during the virtual visits. That said, given the choice, they would choose in-person visits over virtual care. So if we go to the next page, you'll see for well-being programs, this was maybe the biggest aha during the survey, is that most respondents did not know about the well-being programs, such as the health coaches, the gym membership discounts, the tobacco cessation program, etc. Not many respondents were aware of Healthy You, and most respondents were aware of Weight Watchers, but chose not to participate in that program. For the employee assistance program, again, not many respondents had used that service, but again, remember it was in that, that 6-month period at the beginning of the year, I guess 5. Most respondents who did use the EAP were satisfied with the process, although satisfaction levels varied, but not many respondents had actually received any kind of counseling. So we'll look at those in more detail. And then for uplifter benefits, just not many respondents had attended an uplifter benefits workshop, with 64% of people not even aware that that was an option. So we'll go through the slides in more detail for each one of these subjects. I'm going to turn it over to my colleague, Teslin Ishii. She's going to look at medical, dental, and vision, and then I'll take it back over to talk about well-being, the EAP, and uplifter benefits.
Great. Thank you so much, Erin. Yeah, we can go ahead and stay on this slide. So I'll be covering the specific questions that we asked around around medical, dental, and vision plans for the plan year 2023. Just to orient you to what the next few slides are going to look like, we have the questions bolded in that dark navy at the top, and then we'll obviously have the answers displayed in that chart. So whatever's running along the x-axis will be either the answers that they were able to select or the categories that we were asking about. And then you can also see in the green, we highlight the key takeaway. So kind of the most important thing from the slides or the answers that were given, as well as the exact number of responses that we received for each question. So to get us started for medical, as you can see here, as we know, most respondents are enrolled in a Providence medical plan for the 2023 year, with about a quarter being enrolled in Kaiser and about 18% being enrolled in Moda Health. And then we can go ahead and go to the next slide. The next few questions, we asked the same questions in the following sections for both medical, dental, and vision. So I'll go ahead and overview you that we asked about their general satisfaction in these categories that are listed along the x-axis. So we're asking about your premium costs, so your per paycheck deduction, your out-of-pocket costs for services, overall covered services, and then overall satisfaction with your medical insurance plan. So as you can see here, most respondents are satisfied with their medical plan's premium costs, their out-of-pocket costs, and covered services, as well as generally satisfied overall with their medical plan. However, at least 10% of respondents are responding that they're dissatisfied or very dissatisfied in all of the categories, with the most negatively rated category being out-of-pocket costs. So just for the next few slides, I want to highlight that the green and the blue bars are really what we're highlighting, that most people are very satisfied or satisfied, and the yellow and light blue are the dissatisfied and very dissatisfied, as you can see on that key off to the right. We'll go ahead and move to the next slide. Okay, great. The next question was about the level of satisfaction with their medical plan's customer service in the following categories. Again, that's running along the x-axis. So we asked about the timeliness of addressing a customer service request, the ability to answer questions correctly for the first time, helpfulness, their knowledge and expertise, the availability of information, and overall service. So you can see that most respondents are satisfied with customer service categories. In fact, at least 68% in all of the categories. However, about 12% at least in each category are dissatisfied or very dissatisfied with customer service of their medical plan. We can go ahead and move to the next slide. Next, we asked about their level of satisfaction with communications coming from their medical insurance plan. This is around the methods of being used for communications, whether that's email, mail, or webinars, the frequency, how often they're being communicated with, the content, so what they're saying and how they say it, as well as the effectiveness of the communication. Most respondents are satisfied overall with their communications from their medical insurance plan. You can see pretty low dissatisfied and very dissatisfied answers, so that's exciting to see. We can go ahead and move on to the next slide. We asked about the level of satisfaction with their medical plan's website, specifically around the content on the website and the organization, so the ease of use. Most respondents, about 70%, are saying that they're satisfied or very satisfied with their medical insurance plan's website in both content and organization, although about 16% say they are dissatisfied or very dissatisfied. And I'll go ahead and move to the next section. That concludes the medical section. So again, we'll be asking the same questions, but now asking about dental providers. So we start off by asking them to obviously select the dental plan that they are enrolled in for the 2023 plan year. So you can see that 61% are enrolled or were enrolled for 2023 in Delta Dental, with about a quarter in Willamette and 15% in Kaiser, with only 1% saying that they were not enrolled in dental during this time. We can go ahead and move to the next slide. This is where, again, the questions will be repetitive, so you already know what is along the x-axis, so I won't go into depth in those categories. But the first question that we ask is around the level of satisfaction with your PEBB dental insurance plan. So most respondents are reporting being satisfied with their dental plan premium costs, out-of-pocket costs, and covered services. Most respondents also say that they are satisfied overall with their dental plan, with at least 17% of respondents saying that they're dissatisfied or very dissatisfied in all categories except for premium costs, which you can see from that yellow bar and light blue bar is a lot lower at only 9% saying that they're dissatisfied or very dissatisfied. Moving to the next slide, thank you. We ask about the level of satisfaction with your PEBB dental insurance plan's customer service. Most respondents are saying that they are satisfied or very dissatisfied, at least 60% in each category with their customer service of their dental plan. However, this is where Erin's highlight about the specific 5-month period that we surveyed around comes into play, because at least 23% in all the categories are responding not applicable. You can see that orange bar that's highlighted there, potentially meaning that maybe respondents have not interacted with their dental plan customer service in the 5 months that are covered by the survey. So we're seeing some higher numbers for not applicable in this dental category. We can go ahead and move to the next slide on communications. Their level of satisfaction with communications is high and satisfied. They say that they're satisfied with communications at least 65% across all categories. And again, you can see that about 20% responded not applicable. We are thinking that that could be potentially due to the fact that they do not remember receiving communications from this entity within the first 5 months of the month that we're 5 months of the year that we're asking about. And then moving on to the next slide on the medical plan, on the, dental insurance plan's website, we ask about, again, their satisfaction with content and organization. Over half of the respondents are satisfied with their dental plan insurance websites for content and organization. However, again, we see that 32% responding not applicable, potentially implying that they either don't know about their dental plan's website or that they haven't visited these sites recently or within the few-month period that we're surveying. All right, moving to the next slide, that concludes our dental overview. So moving along to vision, we see that most respondents are using VSP for their vision insurance in the 2023 plan year, with about, again, a quarter in Kaiser Permanente and 5% saying that they were not enrolled in a PEBB vision plan during this time. Moving to the next slide. We asked again for them to rate their level of satisfaction with PEBB vision insurance in the following categories. They responded saying that they're satisfied with premium costs, out-of-pocket costs, covered services, and overall, with only about 13% of respondents saying that they're dissatisfied or very dissatisfied in all categories, except for premium costs, which we again see being lower. Moving on to slide 16. We ask about their interaction and their level of satisfaction with customer service for their specific vision plan. Most respondents here are saying that they are satisfied with customer service. However, a large percentage is again responding not applicable, which we're hypothesizing could also be due to the fact that they have not interacted with the vision plan's customer service in the first 5 months that are covered by the survey. Moving to the next slide. Asking about communications, again, we see the same categories. Most respondents are satisfied with communications that are coming from their vision insurance plan, around 60% across all of the categories, with about 30% responding not applicable in all categories. Again, probably implying that they do not remember receiving communications from their plan recently. And then moving to the final vision category or vision question that we asked, which was around the level of satisfaction with their vision insurance plan's website. About half of the respondents are satisfied with their vision insurance plan's website, content, and organization. However, again, those orange bars we see being pretty high, with 35% of respondents saying not applicable, potentially implying that they either don't know about or have not interacted with the vision plan site in the 5 months that we're asking about. So that concludes the overview of the dental, vision, and medical questions, and I'll go ahead and turn it back to Erin to finish the other categories.
Thanks, Teslin. So before I get into the that slide on getting care, thank you. I do, one of the questions you're probably wondering is, will we be sharing these results with the vendor partners? And the answer is yes, we will be sharing these results. We'll be able to cut the data by the different providers to be able to share them, their personalized report. We have not done that yet. We wanted to make sure that we presented to the board first before we sent out these reports. So that will be in the works. So in case you were wondering. All right. And if you do have questions, please raise your hand or jump in or ask in the chat. We are monitoring that. Oh, Greg, go ahead.
So that data that you just talked about, will the board be able to get that as well? Because that might be helpful on
Sure.
the plan and what a plan needs to, maybe there's some difference in something that can move from one plan to another.
Yep, of course. Yep. All right. So I will jump into getting care then. So you can see here on the slide. So the question was it easy or difficult to find care in a convenient and desirable location? Now for these, we are showing medical, dental, and vision all on the same slide. We thought that was easiest for these questions. So the key takeaway is really that most respondents found it easy or very easy to find care in the location of their choice. Now again, for vision, you see that 21% say not applicable. So probably because they hadn't received those services yet. So moving to the next slide. Again, we've combined all the healthcare services here. So how long did it take for you to schedule an appointment with your provider? And so you could see that most respondents could schedule a medical, dental, or vision appointment within a month. However, a large percentage of respondents had to wait 3 months, and some had to wait even 6 months or more. Again, you'll see the high numbers for not applicable for dental and for vision. And I will also say that when we presented these results to the OEB board, because we did a very similar survey for OEB, they made the suggestion about breaking these questions into getting care for primary care versus getting care from a specialist, which we thought was a very good suggestion. And so going forward, we will likely change these questions to ask it about both types of services. So that was a learning for us, but I think that this is another aha from the survey, is just how long people, I think we know people are waiting for services, but to see how long on the survey was eye-opening. So moving then to the next slide around telehealth. So did you use your medical carrier's telehealth features? And most respondents replied that they did not use their telehealth features, although 35% did. And so for those who did use telehealth on the next slide, you can see, were they concerned about privacy during their phone or video visit? You can see that it was a high percentage of rarely or never being concerned about privacy. And then during the plan year, was the quality of care that you received on your phone or video visit better or worse than the care you received during in-person visits? And most respondents found that the quality of care were similar to virtual and in-person visits. Now on the next slide, given the choice, would you choose in-person care or virtual visits for a medical issue that you felt needed to be resolved quickly? You can see that the majority of respondents would choose an in-person visit over a virtual visit. Now, this was another spot when we presented to the OEB board that there was a suggestion about breaking out this question into telehealth for urgent care versus telehealth for other types of care. And again, we thought that was a good suggestion. And so we'll likely be changing these questions in the next go round so that we are differentiating the two different types, or when you might access telehealth. All right, on the next slide, so about well-being services and programs, and I said this in the executive summary, but this was a real aha for us in the survey, is really that most respondents did not participate in the plan's wellness programs, and oftentimes did not know about the programs as well. So the one exception for PEBB is the personalized health assessment, which makes a lot of sense because that is part of the HEM program, and you need to complete that health assessment to participate in HEM. But again, 30% didn't know about the health coaching, the gym memberships and discounts, physical therapy, and pain management services. So this is definitely an education opportunity around the wellness programs that are available through the different vendor partners. Then on the next slide, So it's, please rate your awareness of the plans. This is specific to Healthy You and to Weight Watchers. You can see that for Healthy You, that most respondents are not aware of that program, a very high percentage there. And then for Weight Watchers, people are aware of the programs, but chose not to participate. On the right-hand side, you can see, please rate your satisfaction with these programs. And you can see very high percentages of not applicable. And again, we think that's because they're on the Healthy You side, they don't know about the program, so they're not participating. On the Weight Watcher side, they're choosing not to participate in that program. So those results make sense. And then on the next slide, so this is around the EAP. Did you receive in-person or telehealth counseling through the EAP? You can see that most respondents selected no, they did not. For those who did receive services, how easy or difficult was it to find counseling in the location that's convenient and desirable to you? You can see that most respondents said that it was very easy or easy. So that's nice to hear, although there's a fair amount of respondents who answered difficult or very difficult. On the next slide, related to the EAP and for those who used it, were you able to schedule appointments with the counselor of your choice? The majority of respondents said yes, although there's a fairly high percentage of people who said no. And then for the first time of your initial contact, how long did it take you to meet with the counselor? And most people were able to schedule appointments within a month, but you can see that there was a fair amount of people who needed to wait at least 3 months, and then a group of people who also needed to wait 6 months or more. So those are definitely some long wait times. On the next slide, so please rate your level of satisfaction with the EAP, with the intake process and the customer service. So this included the services provided, the timeliness of meeting with the counselor, knowledge and expertise, availability of information, organization, and then overall satisfaction. You can see for those who used the EAP, which was about 380 respondents, that most were satisfied with Canopy's intake and coordination process and customer service. All right, we have just a couple slides left. So now moving to Uplift Your Benefits. So have you attended an Uplift Your Benefits workshop? Most respondents did not attend an Uplift Your Benefits workshop, with 64% of people saying that they were not aware of the Uplift Your Benefits sessions. And then last but not least, we have a question, Uplift Your Benefits covers many topics. Which of the topics would be of most interest to you? And the majority of respondents indicated that learning about benefits and how to navigate benefits with confidence was the top choice. Wellness was the second choice, and then equity was the third choice in terms of responses. And so that's the last slide that we have, but certainly want to answer any questions that anybody has. And Cindy, if there's anything that you'd like to add, please do.
Erin, help me remember the demographic questions that we asked at the beginning. Those were kind of an abbreviated for this survey, correct?
Correct.
So I just want to let everybody know that the full Real D SOGI questions are going to be incorporated into our future surveys. So ideally, we'll be able to break this information down by those categories also. I forgot to mention that earlier.
Thank you. Emily.
Yeah, thank you for that presentation. It was super helpful. I had a question about the wait times. Is there a way to cross that data with geography so that we know like which counties potentially have the longer wait times? I'm assuming that, it's like a provider access network issue.
Yeah, Emily, that's a good question. Teslin, I'm gonna punt to you on that one because I know that you're the one who's in there looking at all the data.
Yeah, we definitely, as part of the demographics, record everyone's county that they're currently living in. So we can definitely cut the data by that and give everyone a report on that.
Thank you.
if I may follow up on that, thank you for the question, Emily. I think that's part of the analysis that is who sub-segmenting, right? Who are the people who aren't getting what they need in all the ways? And I want to suggest that because so much, especially behavioral health, has gone to telehealth, that geography may not be actually the primary driver in the way that it might have been in other times, which is not to say that it might not be. It might, because again of the broadband differential and access to internet services, for example, in some very rural places. But the analyses, I am interested in some of the sub-segmentation analyses that help us understand what the drivers are, both on the member side of the equation, especially for those wait times, as Emily noted, and also on the provider side, if we are going to wind up pinning it to those drivers.
Okay. Thank you.
Thank you.
Go ahead, Emily.
This isn't exactly related, but what Dawn just shared just reminded me of a question that I've received from mental health providers in general. So yes, several mental health, behavioral health providers are providing virtual services. However, they still are interested in getting some kind of one-on-one or in-person contact in order to get like their weights, their heights and things like that, for medication dosages later. And so in general, I've gotten a lot of questions from mental health providers that, is there an innovative way, to partner up like with some group, some primary care, some group that's used to getting heights and weights and things, so that, because otherwise people are having to do their own weights at home and report them to the mental health provider, and the mental health provider has to trust that that's an accurate weight. So that was just a food for thought. Just wanted to plant that seed, and thank you, Dawn, for reminding me of that indirectly.
Thanks, Emily. Any other questions? I don't think I see any other hands up. All right, well, thank you so much. I'll turn it back over to Siobhan then.
Right. Well, thank you both. And thank you, Cindy, too, for all that information. And again, I know that you're open to ideas from the board around future surveys if additional thoughts come up. And that was the last presentation for today. I do want to acknowledge that we had written public comment from Jennifer Howard. I don't believe she is here to speak to her public comment, and it is about the availability of the GLP-1 drugs. I know that PEBB staff will be responding to her questions as she's concerned that some carriers are offering GLP-1 drugs for weight loss and others are not. And I know we've had the discussion right now that we have an exclusion with all of our plans. So for GLP-1 specifically for weight loss. So again, PEBB staff will get back to Jennifer on her public comments. Do we have any other public comment, Rose?
No, Siobhan.
Okay, thank you. Greg, go ahead.
All right. So since we are starting for 25 and we're moving that direction, one of the things that I've had a few members as well as myself experience, and I'm not sure who we need to talk to, but it's not a problem. It's just maybe to help out the customer as well as some of the places that do glasses for VSP. When I go to the place to get my glasses done, sometimes I don't buy my glasses from the doctor that I see because they are very expensive. And so I will go to another place that takes VSP, But in turn, like this year when I went to get these, I went to Costco. Costco then has to call VSP because there's no number on our card. He told me that there are several places that are several insurances that they get. The card itself has a VSP, my VSP number on it. So what happens is they have to call and go through a series of tones, individuals, yes one, no one, type in your social security number, type in your medical number. And so I don't know if there's a way that can be done, but I know a lot of people do what I do. And we had to wait, not a long time, but I have had a couple of times where I've had to wait a while for them to actually contact VSP to get the number that they just basically type in that says, yes, I'm an insurance individual and I get my benefits. So I don't know, just something to throw out there since I'm here sitting on the board, if that's something we could get put on the card or something that could be done. So thank you.
Thanks for those comments, Greg. Go ahead, Ollie.
I was just going to say, we actually were just scheduling our annual meeting with VSP account management. Oh, there's Valerie. So if you want to make a comment, go ahead, Valerie.
Yes, thank you, Ollie. Greg, I would love to find out the name of the Costco that you went to, because we actually have an entire process that Costco can use so that they don't even have to contact VSP on your behalf, because we are reporting and tracking our members and our dependents. And so it sounds like maybe there's some training that could take place. They have some turnovers from time to time, and sometimes some of the new representatives don't necessarily know how to use the system. So I would have somebody.
Yeah, either reach out, or it's Kennewick, Washington. So it is out of state.
Kennewick, Washington. Oh, yep, Kennewick. I'm very aware of that area, so I can do that. And then Ollie, of course, I will also address that during our client partnership review. So thank you.
Great. Thank you.
Thank you, Greg.
All right, thank you. Okay, I believe that's all the testimony it looks like we have. Your hand's still up, Greg. You addressed the comments you wanted to make, or did you want to say anything further? No, okay. All right, so I believe that concludes our meeting today. We are officially adjourning at 12:25. Appreciate everyone's presentations today and the discussion, and please stay safe out there. We are expecting more bad weather here in Oregon, so.
I won't be here. I suspect I won't be here in February, Siobhan, because of the session.
Oh, okay, good to know. Thank you, Representative Nose.
Okay,
Thank you.
All right, thanks all.
Thank you.
Thank you.